Hello everyone, and many thanks to the Lymphedema team for inviting me to contribute to this educational series, Health is Fluid. My name is Louise Koelmeyer from the ALERT program at Macquarie University, the Australian Lymphedema Education, Research and Treatment Program. It was great to hear Joanne share on the lymphedema prevention program that Lymphedema is doing at the moment. Tonight, I'm going to be talking about implementing a prospective surveillance and early intervention model of care for breast cancer rehabilitation. At heart, I'm a clinician specialising in breast cancer rehabilitation and lymphedema management, and it's really my vision that everyone diagnosed with cancer, particularly breast cancer or other cancers who may be at risk of developing lymphedema, have access to this prospective surveillance and early intervention model of care. So what I'd like to talk about today is giving an overview of what is this prospective surveillance and early intervention model of care, and just briefly review the clinical and governance evidence to support the model of care, which really flows on from what Kathy and Liz presented in the previous seminar. I'm going to talk about the monitoring and early intervention protocol. Then what considerations should you think about in developing a prospective surveillance model of care in your service? And then how you might go about implementing this model of care. And I'm going to share some thoughts about implementing the model of care in both the public and private healthcare sectors. Let's go on this ride together. So what is a prospective surveillance and early intervention model of care in breast cancer rehabilitation? So I guess we're looking at an optimal framework to guide our clinical implementation of a screening method for the early identification and management of breast cancer related impairments, of which we would put lymphedema in there. We know that lymphedema can impact an individual's life physically, functionally, psychologically, and financially. And so if there's a way that we can try to prevent the significant impact of this condition on an individual, I think we should be investing all the resources we can to lessen the impact for an individual at risk of lymphedema. So Nicole Stout and her colleagues in 2012 proposed a comprehensive approach to cancer survivorship in healthcare. And really the goals of her model that she published were to promote surveillance, so really to be looking out, to surveil, to see, can we pick up any side effects, any problems early? To provide education. Education is so important, and I'm often referred to a drip filtering education approach when we talk to women after breast cancer and about lymphedema. I don't think we can just be giving someone a half-hour or an hour session on lymphedema education, tick the box in the protocol that we've completed it, and think, right, they know everything about lymphedema. In my experience, it needs to be drip filtered, ongoing over time as they go through their breast cancer rehabilitation program, because it's interesting that at different times throughout that treatment, a person will pick up different information and take it on board. But education is really important for the individual to be aware of this model of care, to be aware of early signs and symptoms, and also to be aware of what to do if they do identify any early symptoms. I guess this model also introduces the whole concept of rehabilitation. So it's not just lymphedema we're looking at, it's the whole physical functional sequelae of breast cancer, physical impairments that occur. And we want to promote and support physical activity, exercise behaviours, because we know that they're going to give someone a much improved quality of life and better physical outcomes. And Nicole and her colleagues published this in 2012. And then more recently in an ASCO paper, Nicole and Sarah McLaughlin from the United States defined this model here so that rehabilitation should be part of the continuum of a person's care. From the time that they're diagnosed with their breast cancer we need to identify through assessment, are there issues for that individual when they're first diagnosed with breast cancer? Some women may have physical impairments, medical conditions, comorbidities that may actually influence or impact their breast cancer rehabilitation. So to be able to assess them holistically at the time of their diagnosis is really important. And that's where lymphedema assessment really is aimed to begin at the time of breast cancer diagnosis for baseline measurements. Then throughout a person's treatment for their breast cancer, we should be involved in rehabilitation, ongoing assessment, ongoing education, and ongoing intervention if somebody develops any early signs or symptoms of lymphedema, plus other physical impairments that they may experience from the treatment that they're going through. And then lymphedema also moves into the survivorship phase. We know that most women survive breast cancer these days because of the extensive and excellent medical management that we offer. But they are left with ongoing side effects, and lymphedema is potentially one of those side effects. And if we can try to reduce the impact of that condition, then we're obviously doing a better job for the individual. So prospective surveillance, this model of care that we're talking about, is really trying to detect stage 0 or early stage 1 lymphedema. We want to detect lymphedema before we see significant visible signs of swelling. We know from several papers published in the scientific literature that early intervention is much more easier to manage than later stage chronic lymphedema. And we also know at the earliest stages that it's potentially reversible. That's where we want to be. That's where we want to target our intervention. So early intervention tries to prevent progression to late stage chronic lymphedema. And it's my vision that all individuals at risk of lymphedema should have access to this prospective surveillance and early intervention model of care, no matter what healthcare setting they're in. And I think we can say now, after working in this area for 15 years, that the evidence is there supporting it. We as clinicians need to start becoming champions in how we work within our teams to be able to make this happen, to be able to integrate, to implement and translate this model of care into routine clinical practice. So some of the key aspects of this model: we need screening, ideally at time of diagnosis, pre-operatively, if possible, before surgery, so that we can have that baseline reading. And if someone's having neoadjuvant treatment, ideally we want to take a baseline before the neoadjuvant as well. Then we want to implement a monitoring process. So post-operatively, although you may see changes in your monitoring and your measurements that you take, it's good to be connected with that individual to hear and see what's going on. Always being aware of risk. I guess we know from the literature that someone at higher risk who's had a full axillary dissection, a mastectomy, chemotherapy with taxane and full radiation is potentially at a much higher risk than someone who has one sentinel node removed, some conserving breast surgery and some radiation to the chest wall or breast area. So we need to be thinking about risk when we're thinking about this model of care. We know that technology has advanced, and Lee Ward, Liz Dilkey have all described the technology of bioimpedance spectroscopy and how its main feature is to detect early subclinical lymphedema. So it picks up those early changes in extracellular fluid, comparing the at-risk arm to the unaffected arm. As therapists, we want to implement early intervention and early evidence-based intervention. And I'll talk about what that involves. And I guess at the same time, we want these people to have access to general cancer rehabilitation, because there's other issues that occur, such as fatigue, body image issues, reduced body composition, that we need to be aware of while a person goes through this journey. And we want to encourage exercise. These are all components of the model that you as one lymphedema therapist might be involved in, or you might have several members of your multidisciplinary team involved in looking after the person across the journey, across the continuum. So why should we adopt a prospective surveillance and early intervention model of care in breast cancer? So I'm not going to go through the evidence in depth because Kathy Kingsford and Liz Dilkey presented those in the previous webinar sessions. But I will promote that there are key position statements and protocols on prospective surveillance and early intervention model of care in the literature. Peak lymphedema bodies, the ALA, the NLN, some of the peak cancer organisations have published that this area is important, that there's evidence supporting prospective surveillance, early intervention, giving much better outcomes for the individual. In regards to clinical evidence, starting back in 2002 with Robin Box, really looked at this concept, and the evidence has progressed from there, looking at randomized control, prospective, retrospective studies over the years, all showing the benefits of early detection, early intervention, leading to less incidence of chronic or later stage lymphedema. And we're aware too that the current PREVENT study, the interim results are certainly showing very positive outcomes for early detection using BIS technology. So the ALA, the Australasian Lymphology Association, really endorses the need for all patients treated for breast cancer to have that educational program informing them about lymphedema. We know that it can be 10 to 15 years after scientific evidence is published before it translates into the clinical arena. So we're seeing here education is important, as I've already said, and there's still lots of myths out there and lots of anxiety out there for individuals diagnosed with breast cancer in regards to lymphedema. So the ALA is certainly promoting this model of care. So when we assess subclinical lymphedema, we've already heard in this series the bioimpedance spectroscopy BIS, using the SOZO device, which is the latest device, or some may be still using the U400 device, is really the way to go. It's a no-brainer. This technology does what it's meant to do. It measures extracellular fluid, comparing the at-risk to the unaffected limb, and it determines a lymphedema index score. Okay, we know that a change greater than 6.5 points, L-Dex points from baseline, will trigger early intervention. And I was recently involved in a validation study that we've published comparing the U400 and the SOZO device in 3 different positions, lying, sitting and standing, and both devices are measuring what they're meant to do, have good reliability and excellent comparison. So the model of care, breast cancer diagnosis, ideally we want to see women at the time of their diagnosis to be able to start the journey of prospective surveillance and early intervention. We want to do pre-treatment assessment, monitoring and education, and then throughout the journey at regular intervals, be ongoing education, that drip filtering, rehabilitation, support, that psychosocial support is vital, and monitoring. And then if we see a change of 6.5 L-Dex points from baseline or trending in that positive way, then we want to start early intervention as appropriate using complex lymphedema therapy or a modified form, ideally because we're getting it so early. So the monitoring protocol that's recommended is that all individuals diagnosed with breast cancer should have this pre-treatment measurements recorded and have similar measurements repeated at 3 to 6 monthly intervals for the first 2 to 3 years after their diagnosis. Ideally, both arms should be measured to reduce standard measurement error. That already happens using the bioimpedance devices. If you don't have those devices and you're using circumference measurements, you always need to measure both arms. And as I've said, think about the risk for the individual. And you may have two groups after risk stratifying. So a higher risk group, which might need 3 monthly monitoring all the way through for the 2 to 3 years. And then you might have a lower risk group who may have less monitoring. Ideally, you want the monitoring to fit in when these women are coming into their normal routine treatments and be taking these measurements regularly. So what happens when somebody does trigger for early intervention? The guidelines recommend fitting someone appropriately with a class 2, I will say 23 to 32 millimeters of mercury, compression sleeve and gauntlet, ideally worn for 10 to 12 hours a day, initially for a 4 to 6 week period. Now I must say here this point that the garment must fit appropriately. Even though we're looking at subclinical lymphedema, and generally before someone has physical symptoms or signs of visible swelling, some normal arms may not fit into a ready-to-wear compression sleeve. So you need to be very aware and tuned in for the shape of the arm and whether it's going to fit appropriately in a ready-to-wear class 2, 23 to 32 millimeters of mercury compression sleeve. Because if you inappropriately fit that garment, potentially it's going to roll down the arm and dig in and potentially be like a bit of a tourniquet on the arm and be uncomfortable, and the person's likely to take it off and not want to wear it. So just keep that in mind when you are fitting these sleeves. Don't think, well, it's early intervention, subclinical lymphedema, just a ready-to-wear sleeve. The sleeve must be fitting appropriately. And there are some body shapes that women have small wrists but larger upper arms, and they may not fit into the ready-to-wear sleeve. And in that case, you may need to consider custom-made garments. We say wearing them for 4 to 6 weeks because most of the published literature has an intervention phase of 4 to 6 weeks. So in a clinical study, you want everything to be uniform to be able to report the outcomes. In the real clinical situation, with my clinician's hat on, I very rarely remove a garment after 4 to 6 weeks just because the L-Dex reading may have come down. I would want a slow weaning process. I'd want to be keeping monitoring very closely if you're going to consider removing that sleeve. So the 4 to 6 weeks time frame is what the scientific literature is saying when recording outcomes of early intervention and obviously showing benefit. But I would err on caution in that it's not just a 4 to 6 week intervention. We need to look at other signs and symptoms and measurements to make sure that we're getting the outcomes that we're wanting. And you may also do a follow-up review to see, is your intervention working? If it's not doing what you're wanting it to do, like in any clinical situation, you very much need to reassess, think about what's going on, what's causing this additional fluid potentially. It could be relating to the taxane chemotherapy that's going on, or other treatment-related factors. So you've really got to look at this person holistically, look at the measurements, but take it as a whole clinical picture and your whole assessment skills. Ongoing education on risk minimisation education and skincare, really important. And we know from the literature that skincare is a behaviour that women can take on and do in their everyday activities. I often say to put the moisturising cream on the bedside table or next to the toothbrush in the bathroom so that it starts to become part of their routine, part of a habit. And it often takes 6 weeks of doing a repetitive activity before it does become part of their daily routine and habit. We know the Clinical Oncology Society of Australia, known as COSA, recommends exercise during cancer care treatment, and that is really something that everyone can be doing while they're going through cancer treatment. No matter how poorly they may be feeling going through their treatment, ideally you want them to be trying to do some level of activity, some level of exercise while they're going through the treatment. And I guess an advantage of the SOZO bioimpedance spectroscopy device is that it does measure body composition. And I've actually found that really useful with my patients, because it's not uncommon in my experience for women to gain weight while they go through their breast cancer treatment. And that could be that they put on 5 to 10 kilos through their treatment. But interestingly, by giving them some objective feedback at regular intervals, so it's sort of your 3 monthly intervals, if you can show them what's happening to their hydration levels, to their fat mass, to their skeletal muscle mass, I've actually seen that that intrinsically motivates an individual to want to try and exercise, because they're seeing those figures. They want to have some control, feel empowered by seeing that data. Just like when they see the L-Dex, that might help them to start exercising their arms a bit more as well. So I guess the guidelines from COSA are to try to exercise 150 minutes of moderate intensity aerobic exercise and 2 to 3 moderate intensity resistance exercises a week. The key probably with exercise is that you want someone to be doing exercise that they enjoy doing, because they're going to be more motivated and more likely to pursue it. So we know that the evidence supports prospective surveillance and early intervention. We know that we've got technology that can very much measure subclinical lymphedema, and we've known that for some time. The challenge is, how do we put this model of care into practice? And I know many centres across Australia and the US who have seen the literature but find it hard to implement into routine clinical practice. So here's some thoughts about steps that you may be interested in to take to try to see this be championed across the line. And I guess ultimately we want to provide access to this model of care for all individuals at risk of lymphedema. So the first key message would be this one: to be working in a collaborative, multidisciplinary team approach. As therapists, sometimes we might not be working directly in the cancer centre, we might be in a separate therapy centre. But it's really important to be seen, to be heard, to be known within the multidisciplinary cancer team. And sometimes that means that therapists need to go to those multidisciplinary tumour board meetings, case conference meetings to be seen and to be heard, because I really believe it's up to us to educate the multidisciplinary team about lymphedema and this model of care. And with that, we also want to encourage and motivate champions within the multidisciplinary team to come on board and help in developing this model of care within their setting. So it could be a breast surgeon, it could be a medical oncologist, a breast care nurse. You want some key players who understand the model and want to support in getting it up and running within the centre. It's important in the centre that you determine a clinical pathway if you're going to implement this model of care. What I mean by that is there's no use monitoring everyone who comes through your centre, but not knowing what to do when they trigger the early intervention or the 6.5 L-Dex change from baseline. So there needs to be a good protocol in place so that whoever's doing the monitoring, whoever's doing the measuring, knows what to do when the early intervention is triggered. And that could be referring on for compression garment and education and intervention, or it could be that that individual in the team is actually trained to measure and fit the compression sleeve and gauntlet. Really important to do the gauntlet as well as the sleeve, not just one or the other in the initial stages. We also need initial and ongoing education for the staff about the model of care, share the research with them, get them feeling like this is important, for also referrers and for also patients. We want individuals to be empowered to want to participate in this model of care. And we actually found, participating in the Prevent International RCT, that women continued to want to be monitored, wanted to be measured, and actually felt a lot of sense of control and empowerment from participating in the monitoring program. I think if you're establishing this model of care, you should be considering about quality improvement and evaluation. The cycle that anytime you're going to introduce a new program, you want to be able to evaluate it. You're wanting to be able to see what worked well, what didn't work so well, what do we need to change to improve. Very important. And of course, with developing any program, you need to consider what resources are needed, either funding for trained staff to be conducting the model of care, for doing the monitoring, who's going to do it, or also equipment that might be needed. And how is this model of care going to be documented and integrated into the routine clinical program? So I thought I'd finish with 2 examples of how you might consider adopting or implementing this model of care across different healthcare systems. Because some people will say to me, oh, it's easy, you've done it in the private practice because you're in total control, or oh, it's easy in the public hospital because you've got more people there. And I guess I'm wanting to share that I think it's actually very possible in both settings. And as the lymphedema expert, you're probably the one with the most skills, experience and knowledge to be able to get this across the line and work very favourably, not only for yourself and your role, but for the whole team and ultimately to give the patient a much better outcome. So if you're working in the private health sector, whether it's in private practice or within a private hospital, multidisciplinary team setting, key message is you've got to introduce yourself and get yourself linked in with a multidisciplinary team. So you need to go and meet the surgeons, meet the oncologists, meet the breast care nurses. They're the ones who are seeing these patients. They're the ones who are treating these patients. And if you haven't had association with them, you need to introduce yourself. You need to educate them about the potential benefits to them and their patients that you can give them with your skills and experience. You want that multidisciplinary team to be referring patients to you ideally at baseline, at the time of their diagnosis. And in my own experience, I found that the team were really pleased to be able to refer the patients on to me or my colleagues, because it meant that they didn't have to go on and talk a lot about lymphedema, and they actually knew that their patients were getting added value service by referring to see me as part of that rehabilitation team. So seeing someone at the time of baseline, it's really important we do this pre-treatment assessment. Yes, we're wanting lymphedema measurements. That's a key outcome we want from that session, but sometimes that might be the minor part of it. You might have this one-on-one session. The person's only known they've had breast cancer a few days or weeks before, and they're planning either surgery or chemotherapy very soon. You've got to be very in tune with the psychosocial status of this individual. And the lymphedema side, we take the measurements, but it's going to be secondary. But we want to be aware of their support, their physical and functional state, and we want to assess those components, as well as taking baseline L-Dex measurements and other measurements relevant to that individual and to your clinical practice. Following surgery, ideally, if you're in the private setting, you want to see these women to continue their intensive rehabilitation. And although you may determine risk levels for your patients as far as monitoring, even some patients at low risk of developing lymphedema still may have some shoulder mobility problems, some scar tissue issues that you need to see. So I would encourage to see all patients in that post-op period, whether it's 3 to 6 weeks after surgery, when drains are removed. We want to get in, we want to be their support person from a rehabilitation point of view. And at that time, you would always take your lymphedema monitoring measurements as well. Get those L-Dex measurements. The L-Dex is telling a story over time, and we can trend that over time to see what is happening to that extracellular fluid. Then we have ongoing rehabilitation at that 3 to 6 monthly period throughout their treatment and beyond for the first 2 to 3 years. In those early months, you may be seeing someone regularly for that intensive rehabilitation. If you're just doing monitoring, it might be at those set periods. But I would be suggesting that there's a large role for us as rehabilitation and lymphedema therapists to be involved in delivering that physical, functional and psychological rehabilitation throughout their treatment. If someone triggers that 6.5 change from baseline or close to that 6.57 L-Dex points from 0, if they didn't have a baseline, then we want early intervention, measurement and correctly fitting of a compression sleeve with gauntlet that's ideally worn 10 to 12 hours a day for 4 to 6 weeks. Getting them back at the end of that 4-week period and seeing what's happening. Take more measurements, hopefully they're going down, but if not, reassess what's going on, what other intervention do I need to take? And then hopefully, if early intervention symptoms settle, then just ongoing review and monitoring individualised to the individual patient, to their treatment and to their risk factor. So this is a really great model of care within the private sector. It saves other team members work and you become a really vital member of the team because you're often seeing these women throughout all of their treatment, whereas they may be very much linked into the chemotherapy team and medical oncologist for a period of time. Then they switch to radiation therapy personnel, but you're potentially that person who's seeing these women throughout the whole journey. And it can sometimes be a rocky journey, as we know. If you're working in the public hospital or government sector, things may be different and resources are different, systems are different, and often you're working with much larger numbers of patients accessing your services and potential waiting lists to lymphedema clinic services. So again, it's really important that you become integrated within the multidisciplinary team and not just separate to working in your therapy department at one end of the hospital and the cancer centre being at another. It needs to be interaction, physical face-to-face, as well as with your patients. So education is important to support the model of care. Then as a team, after your education of the importance of this model of care, you need to get these champions on board to help determine what the clinical pathway is going to be for every woman coming through that breast centre. Now it could be that a registered nurse, a breast care nurse, enrolled nurse, or even an admin assistant or other team member working within that unit may already be taking a person's weight and height when they come into the breast centre. So this role of monitoring could actually be an extension of taking weight and height to get that L-Dex reading and that monitoring program happening streamlined. Of course, training needs to occur for that individual to be able to take the measurements, but then there needs to be discussion amongst the team about what to do when somebody triggers early intervention. So it could be great everyone having these measurements, but unless you have the clinical pathway of what happens when someone triggers, then there's going to be challenges. Okay, so once that pathway is determined, it could be that one of your nursing staff could be trained up into measuring and fitting of the compression sleeve and gauntlet so that that person is fitted with the garment there and then when they've identified the early intervention trigger. And then part of the referral process may be referred to a lymphedema therapist for that 4-weekly review and follow-up so that they go outside of that routine monitoring within the breast centre. If they triggered intervention, they're then potentially referred to the lymphedema clinic, the lymphedema therapist within the service. Really important, the garment fits well, and really important that there's follow-up to ensure that the individual is supported and monitored and appropriate intervention is had. Ongoing rehabilitation and lymphedema monitoring. If someone goes through early intervention, it may be treatment-related edema that they have, they may be tapped back in to the monitoring program of the multidisciplinary team, but that pathway needs to be there and we need to have ongoing evaluation so that we can look at results of the whole cohort from that particular breast centre and ongoing education and communication at team meetings or presentations at tumour boards is really important. So I'd like to thank you for your attention today, and I hope that I've sparked some interest in how can we implement this model of care. You might be thinking, I'm already doing this, I know all of this and I'm doing a great job. Well done, and maybe we can help you to write up your findings or present them at an ALA conference or a lymphedema or breast cancer conference. Let's work together so that we can achieve the vision I have, that every person at risk of lymphedema after cancer treatment has access to this prospective surveillance and early intervention model of care. And I look forward to the discussions and the Q&A session that follows. Thank you.